Thank you very much for the invitation to Professor Schmidt-Erfurt, and thanks to her group for this fantastic meeting. This is not the first time for me, so I really enjoyed in the past. I'm sure that I will enjoy again this time. Novel classification for CNV based on OCT-A. These are my disclosure, and I think this is my first slide, but at the same time is also a kind of take-home message for this presentation. As you can see from this slide, with the introduction of OCT and OCT-A, we can somehow give up invasive imaging, that means dye angiography, in order to make the proper diagnosis of different types of AMD, and also to follow our patients, and this at least probably in the majority of cases. This is one of the classification for AMD based on fundus appearance, fundus examination, and the neovascular form is, of course, the advanced form of disease. And this is putting together the information coming from histology and clinical assessment, and particularly OCT, structural OCT, that defines the different, the three main different subtypes of neovascularization in AMD as type 1, type 2, and type 3. In the past, we used to refer to the neovascularization as a choroidal neovascularization, but then we realized that there is at least a subtype of them, that is type 3 neovascularization, that is not originating from the choroid. So this is the reason why we should use a different terminology for neovascularization in general and in AMD, that is macular neovascularization. So no more CNV, but rather M and V. And this is a type 1 M and V. You can see it is characterized by growth just beneath the RPE. This was in the past also referred as occult neovascularization, and this is because it was not visible on fluorescein angiography. We have just seen that probably we can do without fluorescein angiography, so probably this is one of the main reasons why we should not anymore refer to this subtype as occult. Also because, as you can see from this slide, we have the possibility to nicely visualize type 1 neovascularization with ICG. So still dye angiography, but it's not occult, it's visible as a late plaque on ICG. On the other hand, with the introduction of OCT-A, we even do not need any more ICG dye angiography, because as you can see here, it's nicely visible without the injection, with just OCT-A. So no more occult. The characteristic for this neovascularization is that there is this growth in the sub-RP space, and there is a large amount of fibroblasts, myofibroblasts, macrophages in the neovascularization, and much more than what was supposed before is characterized by fibrosis. The other important point is that in some of these type 1 neovascularization, there could be a combination of the other two subtypes, so type 2 and type 3, that we will see in a while. In the context of type 1 neovascularization, we also have what we originally described in this paper as quiescent type 1 neovascularization. At the time of this publication on IOVS, we defined this neovascularization as visible on late phase ICG, but without exudation, and these were all treatment-naive cases. Looking at the OCT, or structural OCT, we can nicely see this flat, irregular RPE elevation with a highly reflective material in the back surface of the RPE. With the introduction of OCT-A, it was possible to distinguish this peculiar phenotype even without ICG, so just with OCT. And here you can nicely see this large quiescent type 1 neovascularization well visualized with OCT-A. What was the definition of quiescence? Just not looking at a type 1 neovascularization that was visible on ICG without exudation, but is rather the absence of exudation over 6 months. So a minimum follow-up of 6 months was one of our minimal requirements for the definition of quiescent. Quiescent because it's not just detection of neovascularization that is going to develop exudation, but is really something that tend to stay still and without exudation, so without clinical symptoms. There is still much controversies about this, and particularly the group from Bascom Palmer in recent publications demonstrated a high rate of conversion from non-exudative to exudative for this kind of quiescent type 1 neovascularization. But indeed, in their study, they did not use a minimum of 6 months. I don't know if minimum of 6 months is really important, but for sure I can tell you that in our series, and we have nowadays a very large series, more than 40 AIs followed with these characteristics, we really see very few cases showing a conversion to an exudative form. And we also are analyzing the characteristic in order to better define this kind of quiescent versus inactive new type 1 neovascularization. I will be showing these results at the Macular Society in a couple of months, more or less. I will have a lecture on that. The problem with OCT-A in the quiescent type 1 neovascularization is that that's true, we can see it with OCT-A, but not all cases are visible. This is a nice example in which you can nicely see the late plaque on ICG, but no visualization with two different devices of the neovascularization. This means that around 80% of cases will be well visible with just OCT-A. So it's a good tool, OCT-A, to make a kind of screening for detection of quiescent type 1 neovascularization, but if you want to really make the proper diagnosis, probably you still need to do at least ICG. This is another type of neovascularization that is quite frequent to detect in macular diseases, that is central serous chorioretinopathy. By the introduction of OCT-A, we were realizing that many cases that initially were diagnosed with just central serous chorioretinopathy indeed are complicated by a type 1 neovascularization. So why we were not able to detect in the past this kind of complication of central serous? I will show you a case of quiescent type 1 in central serous chorioretinopathy. So you can see here that in central serous retinopathy we don't have a late plaque for the type 1 neovascularization, but rather we have a washout of the neovascularization. So you have to look at the hypofluorescent on late phase ICG, and then you can nicely see the high correspondence between what we see nowadays with OCT-A and what could be detected on ICG as type 1 neovascularization. Highly correspondent. This was published in Ophthalmology Retina. Then we have type 2 neovascularization. They are growing through the RPE, so in the subretinal space. And they are also called visible because they have passed through the RPE, so they are well visible on FA. But because of this early exudation and leakage of dye, all the details are not visible on FA. They are characterized by, also in this case, by a proportion of fibrosis, and in most cases, this kind of neovascularization that is the less frequent in AMD, and only about 5% of cases, could be just part of the anterior neovascularization. So in most cases we have type 1 or type 3 combined with a type 2 neovascularization. The major advantage of adding OCT-A in these cases is that we can nicely see all the characteristics of the neovascularization as compared to FA. We can also see a draining venule and a feeder vessel. We can also follow the progression of these new vessels and all the network of the new vessels over time after treatment, even though once you have a type 2 that is stable, is no more exudative, it seems that there is not much change over time. Indeed, this is a very important point because what I will show at the Macular Society is the importance not only of the size of the neovascularization in order to get inactivity or quiescent subtypes of neovascularization, but rather the density of capillary networks and the neovascularization. So what is really changing and what we will look at when we do a treatment in the future will be possibly one of the main indications for OCT-A will be the vessel's density and the neovascularization. And size doesn't change. And also possibly once the neovascularization is stable, is no more active, also the vessel density. But as you can see here, they appear very little density of capillaries here, a kind of arterialization of the neovascularization. In the end, we have type 3 neovascularization. Type 3 was previously known as retinal angiomatous proliferation. There have been 3 subtypes described as a possible origin of type 3 neovascularization. And in this publication, at the time we just had unfast structural CT without OCT-A, we were able to demonstrate the very early phases of the disease that were localized at the level of the deep capillary plexus and with a strict relationship with the RPE from the beginning, even in absence of exudation, as you can see from this slide, no exudation on structural CT. Starting from this, we had the chance to look at the very early phases of type 3 with the add of OCT-A and what was previously reported as pigment, as a signature for cases developing type 3 neovascularization. This pigment on structural CT, indeed, with OCT-A already is characterized by flow. So we can detect very early type 3 neovascularization before any exudation and signs of activity on structural CT, but even on FA or ICG by looking at these characteristics in the outer retina and particularly just beneath the deep capillary plexus. This is the same case over time. We looked at the natural history, and of course there was development of exudation. And we also realized that what characterized the development of exudation is this sub-RPE component in the type 1 and the type 3 neovascularization. That is a kind of evolving type 1 neovascularization, starting possibly from the deep capillary plexus. We don't know why we need to have this sub-RPE component in order to get exudation, but in all our cases, when we have just the retinal component for the type 3, it seems that there is no exudation at all. And this is one of these cases. We just published this, and we call this kind of a progression as nascent type 3 neovascularization. The paper was published on ophthalmology retina. So you can nicely see the early type 3 going down from the deep capillary plexus progressively, and still without exudation until it reaches the RPE. Why this progression, this nascent type 3 is extremely important, because some of these we have looked at our seers may spontaneously regress. So again, we really need this communication and the sub-RPE component in order to get exudation and activity for the type 3. And now we can follow over a long time these cases with the help of OCT-A by combining multimodal imaging, of course. this is the same case after treatment. So you have the sub-RPE component, you have the retinal component. Once you do treatment with anti-VEGF, there is no more flow in the sub-RPE space and no more exudation. Once there is recurrence, you have again this sub-RPE component and exudation, of course. I will finish with the atrophic form of advanced AMD, so geographic atrophy. Just to show you that in several cases of foveal preservation and in general of preservation in the context of a geographic atrophy, we may have this type 1 neovascularization. Well, this type 1 neovascularization is still quiescent, 6 months apart. There's not much change in the neovascularization. These new vessels appear as arterialized, so not much capillaries inside the neovascularization. And this is something really important because it seems to be extremely important to preserve the fovea, a kind of a nourishment from the type 1 for the outer retina that may prevent progression. We should not treat these cases, and it was also demonstrated recently. A paper was presented at the American Academy. There's no benefit in treating fellow eyes of neovascular AMD or in treating quiescent type 1 neovascularization. So in conclusion, thanks to multimodal imaging and the introduction of OCT-A, we may give new names and also better interpret the progression for the different subtypes of neovascularization, and possibly in the future will be one of the main tools for diagnosis and following patients with neovascular AMD. Thanks for the attention, and thanks to my group.